Buongiorno a tutti e benvenuti, bentornati a chi ha partecipato al primo evento e benvenuti per chi è la prima volta. Siamo molto felici di essere qui in persona, anche perché eventi come questi vi renderete conto nel corso di queste 2 giornate che la modalità virtuale non aiuta, non è qualcosa che rientra nelle corde di un evento come questo. Io ritorno a fare un'introduzione molto simile a quella del primo anno. Primo anno, per chi c'era, si ricorderà che ho parlato del ponte di Brooklyn e questa volta ho scelto un ponte italiano che è il ponte di Rialto. Il ponte di Rialto ha un'arcata di 28 metri, questo consente anche alle navi e alle imbarcazioni più grandi di passare sotto. Ha delle fondamenta di palafitta che sono vecchie quasi di 500 anni, fatte di olmo e di larice. Sono circa 6.000 pali per riva e il ponte raggiunge un'altezza di 7,5 metri sopra la media di marea. Le più antiche colonie veneziane sorgevano sull'isola di Rivo Alto e lì avvenivano gli scambi commerciali e l'armamento delle navi, e quindi nasce la necessità di avere ovviamente un collegamento del Canal Grande sulle 2 sponde. In realtà il primissimo abbozzo del ponte che noi conosciamo era un semplice accostamento di barche, erano barche affiancate una all'altra, quindi capite che questo creava non pochi problemi, anche non fosse altro per la navigazione. Poi solo nel 1181, il Doge ordina la costruzione di un vero e proprio ponte in legno poggiato su delle palafitte, e questo subisce vari crolli nel corso del tempo, ma viene sempre ripristinato su questo vecchio modello, e solo durante l'ultima costruzione si fa una piccola modifica, viene sistemata una specie di levatoio in mezzo in maniera tale da poterlo alzare quando passavano le imbarcazioni più grandi. E poi un secolo più tardi viene realizzato il primo ponte con una struttura in legno su pali che viene distrutto diverse volte. La prima volta durante una rivolta popolare nel 1300, ricostruito allo stesso modo, e poi nuovamente distrutto rovinosamente nel 1444. La popolazione di Venezia si affolla, si accalca sul ponte per vedere passare la marchesa di Ferrara sul canale e il ponte cade. Allora a quel punto si decide di fare un bando per costruire un ponte in pietra e partecipano grandi nomi, fra cui Michelangelo, il Palladio. Il Palladio oltretutto propone un ponte a 3 arcate che ovviamente non va bene per il contesto in cui deve andare a collocarsi, e vince Antonio da Ponte, che propone il suo progetto. E in realtà prima di prendere il via i lavori ci mettono un sacco di tempo, prima di tutto perché la gente non vuole che questo ponte venga ricostruito, la gente ha sempre qualcosa da dire e pensavano che questo andasse contro il commercio, quindi non volevano che il ponte fosse costruito, ma finalmente nel 1589 si dà il via alla costruzione. I lavori sono complicati, spesso vengono interrotti. E poi siamo sempre nel Medioevo e quindi ci sono falsi miti, quelli che si chiamerebbero oggi fake news o le notizie sui social, anche lì c'è qualcuno che fomenta dietro, ma soprattutto si narrava addirittura che l'opera fosse ostacolata dal diavolo in persona, che aveva interesse nel far sì che il ponte non venisse costruito, e si diceva che avesse fatto un accordo con Antonio da Ponte, con l'architetto, dicendo che si sarebbe preso l'anima della prima persona che avrebbe attraversato il ponte. Allora Antonio accetta, ma ci pensa e decide di far passare un gallo. Quando il ponte è pronto fa passare un gallo, purtroppo però il diavolo non ci casca, e sotto mentite spoglie approccia la moglie travestito, la moglie di Antonio da Ponte, dice di raggiungere il marito e fretta e furia. La moglie lo vede al di là dal ponte, lo raggiunge e la leggenda narra che il diavolo si impossessa della sua anima e condanna quella del nascituro a vagare per secoli senza riposo. Sta di fatto che gli intoppi fossero di natura ingegneristica, economica o metafisica, viene finalmente ultimato nel 1591, così come lo conosciamo. Anche le botteghe sono state progettate da Antonio da Ponte e praticamente per 300 anni è stato l'unico modo per raggiungere le due sponde del Canal Grande. Adesso ci sono il Calatrava, il ponte dell'Accademia e degli Scalzi, però fino ad allora c'è stato soltanto il ponte di Rialto e le pietre utilizzate per la costruzione erano un dono del vescovo di Padova, che pagò così dei debiti alla città di Venezia. Mi mandate la mia presentazione, per favore. Verrebbe sicuramente spontaneo chiedersi perché ci racconta di nuovo questa storia sui ponti. Serve un bisogno, e noi di bisogni in oncologia toracica e specificatamente per il tumore del polmone ne abbiamo tanti. Lì il bisogno era collegare una zona della città e fare in modo che il trasporto fosse adeguato. Serve fantasia e perseveranza, perché a volte serve un pizzico di fantasia per costruire le cose e queste devono avvenire con perseveranza tutti i giorni. Uno ci crede e continua ad andare avanti, all'inizio magari anche non con l'opera che viene considerata quella finale. Poi sicuramente serve il progetto, quello di Antonio da Ponte è stato il progetto, i progetti di costruire un ospedale, un day hospital, il progetto nel costruire uno studio clinico. Serve una progettualità, ma serve farlo con consapevolezza. È inutile pensare ad una cosa che non ha un significato in quello specifico contesto, così come è stata l'idea di Palladio, anche se era veramente una grande mente. Serve scienza e disciplina, perché ad un certo punto bisogna dire basta, quando serve la scienza per dare una dritta, quando non servono più tante parole da parte di persone che non hanno le competenze per poterle dire. E poi quando il ponte è costruito ci vuole il coraggio per attraversarlo, e questo coraggio è l'alleanza terapeutica che si forma tra noi e voi tutti i giorni, con costanza, con perseveranza e con un pizzico di fantasia. Benvenuti a Roma. Io colgo questa occasione anche per ringraziare. Solitamente so benissimo che i ringraziamenti vengono fatti alla fine, ma il problema è che alla fine c'è sempre qualcuno che se n'è già andato, siamo tutti più stanchi, invece io voglio iniziare ringraziando tutte le persone che hanno contribuito, ma contribuito veramente alla realizzazione di questi 2 giorni. Sicuramente Stefania e Cristina che hanno lavorato, ormai lavorano da mesi a questo progetto e chi è qui lo sa perché ha ricevuto telefonate, mail, quindi grazie mille a loro. Grazie a tutto il direttivo di WALCE che oggi è qui presente e a cui chiederei di alzarsi in piedi per fare loro un applauso. E chi non è del direttivo di WALCE ma che collabora costantemente con WALCE, a cui chiederei di alzarsi in piedi per far loro un applauso. Sara, Simona. Grazie. Un ringraziamento col cuore in mano a Valce Puglia. Anna Maria quest'anno non può essere con noi per motivi personali, sta bene ma ha una questione familiare da gestire, ma Mimmo, il dottor Galetta è qui, grazie. Ringrazio Doc Congress, ringrazio Angela in particolar modo perché ci accompagna ormai dalla prima edizione e lo fa con passione ed edizione, ma tutta Doc Congress veramente si presta non come un'agenzia ma come una compagna di viaggi. Gli sponsor sono tanti e li ringrazio tutti e sono la testimonianza che con le aziende farmaceutiche si viaggia insieme, non è un rapporto positivo, è sempre un rapporto di scambio continuo e di condivisione di progettualità. E ringrazio tutti voi per essere qui presenti oggi, perché so benissimo che uno, gli impegni sono tanti, e due, questa è una malattia che porta via tanto alla vita delle persone, quindi essere qui è un investimento. Chiedo quindi che venga lanciato il video di inizio.
Ciao Silvia, sono Marcello Tiseo, professore associato di oncologia medica presso l'Università degli Studi di Parma e do a tutti il benvenuto qui a Roma.
Hi there, I'm Alex Drillon, a medical oncologist at Memorial Sloan Kettering Cancer Center in New York.
I am Dr. Suresh Ramalingam from the Winship Cancer Institute of Emory University in Atlanta, United States.
Sono Marina Chiara Garassino, sono professore di medicina all'Università di Chicago e direttore del Centro di Oncologia Toracica.
Thanks for inviting me to give a little talk at the beginning of your second Be MUT-ual Day in Rome.
Nel 2004 due gruppi di ricercatori in America hanno scoperto le mutazioni di EGFR e noi abbiamo iniziato a vedere come alcuni farmaci a bersaglio molecolare producevano degli effetti straordinari nelle persone che avevano proprio queste alterazioni.
As highlighted in New England Journal of Medicine last year, the progresses and the decrease in the rates, in the mortality rate for lung cancer patients goes from 3% per year between 2008 and 2013 to 6% in the decrease of mortality for lung cancer patients between 2013 and 2016.
This has been made possible by more effective therapies and precision medicine approaches.
We not only have a rising number of oncogenic drivers that are found in lung cancers, but these are also paired to many highly active targeted therapies such as next-generation tyrosine kinase inhibitors and antibody drug conjugates.
Gli ultimi 15 anni sono stati ricoperti da scoperte incredibili, in particolare abbiamo trovato tantissime nuove alterazioni, ALK, ROS, BRAF, la mutazione di ER2, abbiamo trovato MET exon 14, RET, TRAC e quest'anno negli ultimi 2 anni anche KRAS, che per noi sembrava essere veramente un target assolutamente irraggiungibile.
Oggigiorno abbiamo circa il 20% dei pazienti che possono ricevere sul territorio nazionale farmaci registrati con queste caratterizzazioni molecolari, ma ci appropinquiamo ad avere probabilmente a breve circa il 40% dei tumori polmonari a piccole cellule che riceveranno una terapia a target molecolare.
I think we are a true global community and we have made incredible progress in lung cancer. I think we are seeing things in lung cancer that were unimaginable years ago. That's the new reality. Long-term lung cancer is what it should be. It should be a footnote in people's lives and not the headline.
Now it is up to us to make sure every patient with lung cancer is tested for molecular drivers, is treated with effective agents, and we further pursue research to improve outcomes for patients with resistance to targeted therapies.
È fondamentale la relazione medico-paziente, è fondamentale che voi ci comunichiate ogni cosa che vedete, perché sono sicura che tutti insieme è più facile e sarà più facile.
Together, this will be easier.
Together it will be easier.
Together, it will be easier.
Together, it will be easier.
Insieme è più facile.
Avete visto il programma, la giornata è organizzata in 2 parti. In questa prima parte avremo un update su quelle che sono le novità e l'immediato futuro nel contesto specifico della malattia oncogene addicted per il tumore polmonare non a piccole cellule, ma ci saranno anche 2 testimonianze, una di una paziente italiana e una di una paziente inglese. La seconda giornata invece è completamente dedicata a voi, le tematiche le abbiamo scelte noi, per il prossimo anno potreste sceglierle voi direttamente, ma le abbiamo scelte noi su suggerimenti che sono emersi durante la prima edizione e quindi i 2 gruppi di lavoro si concentreranno sulla ricerca clinica e sulle terapie di supporto, sperando di ottenere tanti messaggi da parte vostra e progetti futuri che WALCE sarà lieta di aiutarvi a realizzare. Detto ciò, il video è espressione di quanto ci sia in termini di network e collaborazione sul territorio italiano. Il non sentirsi soli vale per noi come clinici, l'avere sempre punti di riferimento anche in altri paesi, in altre strutture, e vale per voi per essere coscienti e consapevoli che quello che viene fatto in accordo ad una voce comune, a un qualcosa che è una modalità di lavoro presente anche in altre realtà a livello mondiale. La mia percezione dell'importanza del network è iniziata durante una esperienza fatta ormai parecchi anni fa all'Institut Gustave Roussy Villejuif in Francia, che come sapete è una delle istituzioni più importanti, più rinomate in termini di ricerca clinica, preclinica, ma di attività clinica in sé, non soltanto per la struttura, ma perché ci lavorano persone d'eccellenza ed è quindi per noi un onore e un piacere avere di nuovo il professor Benjamin Bess per la seconda volta a farci un update di quelle che sono le novità in ambito terapeutico. È una persona assolutamente a modo, molto disponibile, quindi ci sarà la possibilità anche di un'interazione al termine della presentazione, qualsiasi siano le domande che vi verranno in mente. So it's a great pleasure for me to introduce Benjamin Bess. Merci Benjamin pour être là pour la deuxième fois. Et à toi.
So, hello, thank you for having me for the second time. I will speak in a very simple English, like a child. So if you want to listen my English, I have a very typical French accent, not difficult to understand. And also it's translated. First of all, we have to be very humble, and I want to be humble. We have done a lot of progresses, like we said, but it's different to live the progress from our side, where we see all the changes, and from your side, where you live the changes. And sometimes there might be some frustration for the patients, because all the time you hear there are advances, but for me, what are the advances? These are my disclosures. It means that I know things from the pharma industry, but the money of the pharma industry goes to my hospital. I don't touch the money myself. So we are talking about oncogene addiction. We are talking about oncogene addiction since roughly 15 years. Since that time, we understood that lung cancer is not one disease. It's a number of diseases, and it's probably even more than is all these color plots, probably much more. So the thing that we discover is that each lung cancer is a rare tumor, and of course, each patient is different. So what I want to highlight today is that we cannot treat lung cancer as a whole. Sometimes I have patients that said, I have lung cancer and my father had lung cancer. And I always told these patients, you are not the same patients, but most of all, this is a completely different disease. So we are talking about addiction, and you know the term addiction, to be addicted to something, and this is a term we have used for the cancer because the cancer is addicted to something. in some cases. I will take the example of EGFR because it's the first gene that we have targeted. EGFR is a gene in the cancer cell. It's important to say that it's in the cancer cell because you know that in all our cells we have all the genes. And what is a cancer? It's one of our cells that had additional mutation, and this normal cell became a cancer cells. So in 10% of the cases, mostly in never smoker, one gene can be mutated, EGFR. It's mutated in the tumor cells, but not in the gene of the patient. It means? Is it okay? So now, perfect. So just to wrap up, I was explaining that lung cancer is not one disease, it's a number of different rare diseases. And I was explaining that in 10% of the cases, there is a gene that is mutated called EGFR. The gene is mutated in the cancer cell, but not in the normal body, meaning that we are talking about these mutated genes. This is not something that the patients can give to its children. It's very different from what we call a germline mutation, where this is a mutation that is in your gene from the beginning. This is really something that is different from your gene. It's in the cancer. And when there is EGFR, we call it in French talon d'Achille. It means that there is a point of frailty for the tumor. When EGFR is mutated, the tumor is addicted to the signal of EGFR. The tumor can live if EGFR is activated. So if you cut the signal of EGFR, the cancer cell is so dependent to this signal that either she will die or she will stop to divide. So this is a very strong way to attack the tumor cells. So the first one to be described and targeted was EGFR, and then there was ALK, and then there was ROS1, and a number of additional abnormalities were found. EGFR, the drug, was approved in 2009, and since we have almost every year new drugs for a target that we know, we call them new generation, or new drug for new targets. So it's really a field that is moving very rapidly. If I take the example of EGFR, in fact, you can translate that to all the other abnormalities. It's always the same story. These abnormalities are very rare, so 10% for EGFR, but you see, ALK, it's only 4% of the patients, and it's mostly never and light smoker. And this was that at the beginning. That was mostly those patients in which we were looking at these abnormal genes. But now we have a number of genes that are also mutated in smokers. So the genes are found in the cell, in the nucleus of the cells, and we have very precise way to analyze these genes. So when we know what we are looking for, we can be very, very specific, precise, and very sensitive. We can catch even a very small fragment of DNA. And now we have almost 10 targets where you saw less than 15 years ago we had only one target, and the field is probably growing. When you have a target, you might have a drug that works, so it's called a chance because you still have the regular ways to treat, like chemotherapy, but you have additional drugs, so it's additional chance. It's called precision medicine because the drug is given to the patients only if the gene is abnormal. So one patient with a mutation EGFR will have specific drugs, one patient ALK will have other drugs. And when you have a abnormality that is in 1% of the population, well, this 1% will have its own treatment. So when you have a diagnosis of lung cancer, you have many steps. You have, you know, the CT scan, the PET scan, then the biopsy to be sure it's a cancer. And then now you have a next step that is called molecular profile, where you have to know which gene is mutated in the cancer. You have to know it as soon as possible because in most of the cases, it will change the way you treat the patients. So the first important thing is to look for this mutation. We call it screening. So we have a number of different technology to look at these genes. Whatever the name of this technology, the term you might hear is NGS. It's one of the technology to look at this mutation or fusions. But if you see, you can find easily this abnormality in never smoker, the patients that never touch a cigarette, or in the light smoker, look, it's the patients that smoke 1 pack a year less than 50 years, so we call them light smoker. And even in this population, the number of mutations you can target is lower. And we have all these technologies, but to apply these technologies, we need tissue, we need the biopsy. And when you have a biopsy, usually you take a very small amount of tissue, and this is one of the limits. In a third of the case, there is not enough material to test this mutation. So we are very fortunate that today we have additional technologies called liquid biopsy. In the blood of the patients, we can catch very small fragments of the genes, of the chromosomes, and we can analyze this in the blood. Initially, this technology was developed for pregnant women. The goal was to catch in the blood very small fragments in the blood of the mother, very small fragment of the DNA of the child. And this technology was adapted to cancer in order to catch in the blood very tiny fragment of tumor DNA and analyze them. And this technology is really rising as a surrogate technology to the biopsy that are very invasive. So we are making progress in screening, but we still have to fight a lot to get these results. Then if you have a gene, you need to have the therapy. So if I take the example of EGFR, as I said, when EGFR is mutated, there is a very strong signal of EGFR, a signal that says to the tumor, divide, divide, divide. It's a signal very strong for the tumor. So the cancer will grow because the cells are dividing because of this signal. As I said, if you stop the signal, you will stop the growth of the tumor. What is EGFR? It's very simple. Here you see the surface of the cell. It's what you see here. EGFR is in the middle of the surface of the cell. So it has an external part where there will be a ligand, a signal, and there is an internal part where the signal is given to the cells. We have many ways to inhibit this EGFR. The first way is to give small molecules that will enter the cells, so usually it's oral drugs. You take daily or twice daily, it enters the cells and it will inhibit the signal inside the cell. It's called kinase inhibitors. So for EGFR, we have these inhibitors, and this is the way we represent the efficacy of a drug. I will not show any survival curves today because I don't think it's really relevant here. It's more, we are not talking about survival, how long it works. We are really talking about what is the sense and why we design these drugs for oncogene addiction. So here you see each column is a patient. If the columns goes up, you have the 0 line. If it goes up, it means that during treatment, the tumor grows. If it goes down, it means that during treatment, the tumor is reducing. So what it means here is that in most of the patients, the tumor reduced. It's a very, very powerful signal, something that you don't see with the classical drug that we have like chemotherapy. It was the first EGFR, the first attempt in lung cancer to say, yes, if you have a good target and a good drug, it's a good match, and you have responses. But then, so we have two generations of EGFR inhibitors with, let's say, a range of activity a bit different. But at one point, some of the cells will find a way to escape the drug. For the first generation, in most of the cases, it's a new mutation called T790M. It's very simple. The kinase inhibitor inhibits EGFR. If you have a mutation, it changes the way you have the pocket and it cannot enter anymore. So this is the classical kinase inhibitor. Imagine that you have T790M here. It modifies the pocket, and then the old kinase inhibitor cannot enter and inhibit. You have to design new drugs. So there are new generation of drugs that are, in some cases, able to overcome the resistance. This is what we call third generation inhibitor. But at some point, the cells will learn how to resist to this third generation, and we have to look at for new generation of drugs. So if you start with the first generation, as I said, if you want to look for the T790M mutation, today you don't have to do a new biopsy. You can start with a liquid biopsy, and then you give the good treatment based on the results of the test. So when you give the third generation, in some cases, you can have new resistance mutation. They have a very crazy name, C797S. And then when there is this mutation, the third generation is not able to enter. The shape of the pocket is again different, and the new drugs cannot enter. So we are building new drugs, fourth generation, but the situation is more and more complex because all the patients will have different panel of mutation. So we will go to a point where even if you have EGFR, which is 10% of the patients, the way you resist to the drug will be very unique to each patient. And probably we will have to give this fourth generation or cocktail of drugs, and it will be very different for each patient. So it's more and more and more complicated. The way we do to understand how to best treat the patients is to sit around the table and to discuss each case with the biologist. We call this a molecular tumor board. So clinicians and biologists are around the table. It's a very, very nice time during the week. We do it once a week. We discuss lung cancer, but also very, very different type of cancer. And we decide all together based on the biology, which is the best way. One thing that is emerging is that sometimes Europe said, well, this is a very good drug for this target. I approved, and then the drug is approved in Europe. You can have access, in theory, to the drug. But then the second step is in each country to decide if we refund the drug or not. This is an example. In France, we used to refund very much the drug, but the situation has completely changed. Example, entrectinib is a drug in the tumor with a fusion in TRAC, whatever, it's a very rare abnormality, 0.3% of lung cancer patients. The drug is very active. The French regulator said, well, it's active, but I don't know, I will not refund the drug because maybe chemo is also active in these cases. We, as clinicians, we know that when we use chemotherapy, the efficacy is very poor, but we have no way to convince the health authorities to change their way. So the drug is not refunded, but when you see the graphic, all the patients, almost all the patients, had some degree of efficacy with the drug. I have 3 patients treated with this drug. They were really from being in a wheelchair to being like you and me. And there is no way to refund the drug. The only way is probably for the patients to go and see the health authorities and say, well, if you don't refund the drug, it's not ethical. But we need the patient's voice. As physicians, our power is very limited for these regulators. This is a new issue that we are facing because we are finding so much targets and we have so much drug that this is a situation that is more and more frequent. What is the best strategy? Well, if we take the example of EGFR, you can start with an old generation, first generation, second generation, third generation. Then you can find the resistance mutation, adapt the treatment, and sometimes physicians are a bit lost. There are so many possibilities. What is the best choice for my patients? Well, this is something we should discuss a bit together because there are different factors like toxicity and in some country the price. But as academic, meaning the research that is done by ourselves, not by the pharma company, we have to ask this question, and this is an example of a trial where we have compared third generation or first generation followed by third generation. So the patients that have accepted this trial were all treated, but there was a randomization between one strategy or the other strategy, and we will see what is the best strategy. This is something we have to do to increase the knowledge. If we move to ALK, ALK is like EGFR, three generation, but here we cannot explain really the mechanism of resistance. There are a lot of mechanisms of resistance, so we are, let's say, very stupid in this way. We start with first, when you fail, second, when it failed, third. But we hope that in the future we will apply the same idea of looking at how the tumor evolves and how we have to customize the treatment. One thing also that is important is maybe to explain to patients that if you take a drug that is a fixed dose, maybe the quantity of the drug in your body will be different. If you take a guy that is 100 kgs versus a lady that is 40 kgs, they will both take the same amount of drug because it's one pill and it's 150 milligrams, for example. When in fact we have done the exercise to dose the drug in the patients, and we have found that the quantity of drug can be very different across the patients. And it seems that the quantity of the drug might be related to the efficacy of the drug. There are a lot of causes for that. Why? Well, you might, for example, take additional drug that can interfere with your drug. And we all know that if we all take one glass of wine here, some will be completely drunk, some will not be, because we don't have the same enzymes. We are born like that. Some will have very active enzymes, some will not. So we are different, and we will have to learn probably to adapt the treatment based on your metabolism. Something also that you experience is toxicity, and toxicity might be sometimes important at the beginning, and with time, because you learn to deal with it, because the body gets used to it, because there are some phenomenon called tachyphylaxia. It's just that the body gets used to the toxicity decreases. Imagine that the toxicity decrease, but also the efficacy decrease. Maybe we could, in some cases, escalate the drug and maybe increase the level of the drug in some patients. This is a concept called late phase 1 that we try to develop in our hospital to say, well, if a patient fails a drug, maybe it's because the patients have not enough quantity of the drug in the blood. Immunotherapy is something you hear a lot. We talk a lot about immunotherapy. It's very fashion. What about immunotherapy in this very specific topic of oncogene addiction? Well, when we see a new patient, basically, we look at two different things. First, is there a target, an oncogene addiction, EGFR, ALK, ROS1? So it's, let's say, between 20 and 30% of the cases. If we have a target, we give targeted therapy. It's very simple. If we don't have any target, we test for something in the tumor called PD-L1, and based on the level of PD-L1, we give either immunotherapy alone, either chemo plus immunotherapy. But for those patients that receive targeted therapy, at the time of resistance, maybe immunotherapy would be a good drug. Well, what we know is that the level of PD-L1 that is related to the drug activity, to the immunotherapy activity, is quite similar in these patients, but there are less patients with very high level of PD-L1. And if you look at the efficacy of the drug, this is a complex slide, in fact, there is no rules. In some abnormality, the immunotherapy will be very potent. In some abnormality, it will be not potent at all. So there is no rule. In some cases, it's a good idea to give immunotherapy. In some cases, we should not give immunotherapy because maybe we will do more harm than benefit. Roughly, if we want to summarize in a simplistic way, the patients that have never smoked or smoke very little usually are not very sensitive to immunotherapy. One thing also is that when you give immunotherapy, it's an IV, so you receive the IV each 3 weeks. The drug stays in the blood for 5 months. So when you receive the IV for 5 months, you still have a drug in the blood. So imagine in a patient you stop immunotherapy and then you start targeted therapy. In fact, when you start the targeted therapy, you still have drug immunotherapy in the blood. So there is an issue during a few months. The patient will have both drug in the blood, the pills that he takes daily, plus the immunotherapy that stay in the blood for 5 months. And there we can have abnormal toxicities. So sometimes it's not very convenient to give a treatment right after an immunotherapy. So 2 issues with immunotherapy. First, will it be potent on the tumor? First question. Second question, do I risk some abnormal toxicity? Finally, new drugs. It will be quite short. So I told you that what we do most of the time is that we inhibit, you remember, the tumor cells. EGFR is in the middle. We target inside the cell with tyrosine kinase. Well, we start to do the opposite. We target the external part, the one that is outside the cells. And for that, we have antibodies. So this is an example of what we can do. We can add the blockade inside the tumor cells with the little drug that you take orally and with the antibody externally. And the combination seems to be very potent in some patients. So double blockade, more potent, more toxicity, of course. So it's not that easy, but it's a way that is very much developed today. Something that is also very fashion today is what we call antibody-drug conjugate. Here, you target the external part of the protein, but the antibody is linked to a chemo. We call them smart chemo or targeted chemo, vectorized chemo. It's chemo, but you put an arrow on it, and the arrow will go directly or in a more easier way to the tumor cells. These are very interesting tools for the patient with or without molecular alteration. So when the antibody goes to the cell, the antibody will bind the cell, and then the antibody will be internalized by the cell, and the chemotherapy will be free inside the tumor cells. It's a very interesting concept and very potent. This is an example of a drug that is given in patients that failed the EGFR inhibitor. And it seems that this drug, for example, is very interesting. It's chemo. It feels like chemo for the patients. You can lose your hair, for example, like for chemo. You can have nausea, asthenia. So even it's fancy here on the paper, for the patients, the feeling is still the feeling of a chemo. You know, asthenia the first week, and then you recover for asthenia, this cycle that you live with chemo. But still, it's interesting because we might give different chemo to different patients and to different tumors. Finally, can we prevent I guess that most of you are light or never smoker, and probably most of you wonder, why do I have this cancer? I never smoke. There is no reason for me to have cancer. And this is really, this no chance situation is really frustrating. There are very few cases of germline mutation. So when a patient is a never smoker with a lung cancer, there is no risk to give to his children a higher risk of lung cancer. But is it pollution? Is it something else? So those questions, we also have this question. Maybe something that you forget or people forget is that after tobacco consumption, the second cause of lung cancer is radon. Radon is a gas that you can find in the atmosphere at different level when there is granite in the floor or volcano. The rate of radon will be higher than in other regions. So it's very different across the regions. When radon is high, there is a risk of lung cancer. The question is, if radon is high, is there a risk of EGFR, a risk of ALK, a risk of ROS1? Because lung cancer, as I said, is not one disease. It's very different disease. And the question we ask is radon the cause of one or a few types of lung cancer? We did the exercise in France where we have matched the results of the molecular abnormality to the radon exposure. So you can see on the right side, you can see France and the rate of radon. You can see that there are areas where there is no radon, an area where it's very strong. In the center, it's called Massif Central. We have volcanoes here, so it's very, very high. And we have looked at what is the rate of mutation of this patient. It seems that when radon is higher, we have more mutation. So to study that, we will start a European initiative called BioRadon, where the patients will be asked to participate, fulfill a questionnaire. Where did you live during your childhood? Later, what floor, because depending on the floor, the radon exposure is different, which region, of course. And we will give patients what we call trackers. It's very small boxes to analyze the rate of radon where they live. Because if we want to act on radon, it's very simple. You can just open your windows, in fact, and it decreases the level of radon in your home. But it's very important to know if this is a risk factor for your children of lung cancer, of specific lung cancer. So my last slide is that we had a lot of successes with targeted therapy, definitively. As physicians, we are very happy to have more and more tools to treat the patients. But as I said, for the patients, it can still be a bit frustrating. We still need to be a lot. Access to screening. Do you have the mutation? This is a key question. Access to drug and the drug to be refunded. What is the best strategy when we have different generation of drug? Where is the best way to treat the patients? And of course, understand and eventually prevent the cancer. Thank you.
Potete fare delle domande tranquillamente in italiano, tanto il professor Bessa la traduzione o comunque io posso tradurle e ci saranno un paio di persone che passano fra di voi con il microfono. Serenamente, senza problemi, non siamo né a scuola né a un esame, è veramente un momento di confronto. Credo che abbia mandato tanti messaggi anche per quanto riguarda la possibilità di partecipare a studi clinici, quanto siano importanti quelli sponsorizzati piuttosto che quelli accademici, quali può essere il vostro ruolo anche in studi clinici diversi, come quest'ultimo che avete sentito in merito ai fattori di esposizione, quanto si possa fare da parte vostra in valutazioni e osservazioni, quindi tanti spunti che probabilmente serviranno anche durante la giornata di domani, però se avete delle domande. Sì.
Buongiorno, sono un caregiver della signora. Mi ha colpito molto il discorso sul dosaggio relativo al peso del paziente. E è una cosa che pensavo anch'io. Un dosaggio elevato per una persona piccola rispetto a un dosaggio, diciamo, medio per una persona di grande peso. Però mi ponevo un'altra domanda. Il dosaggio giornaliero, è pensabile che un dosaggio più basso ma modulato lungo il tempo della giornata sia ancora più efficace? È uno spunto.
Il est un caregiver. Il va te demander sur le dosage.
Ouais,
S'il y a un usage de dosage.
Buon francese?
Pendant la semaine aussi. Différents dosages pendant la semaine.
So the level of the drugs might be different. There is in medicine there is something called chronobiology, where some physicians study very deeply the metabolism of someone during 24 hours. During the night, you don't have the same metabolism than during the day. And for chemotherapy, we did that. There is a thing that chromochemotherapy, where you give the chemo with a little pump at home, and the dose of the chemo is different during the night and the day. What we show is that it did not increase the efficacy of the chemo, but it decreased the toxicity of the chemo. This is something feasible with a chemo by blood with a pump. This is not something that we can do with a pill. So during the week, you don't have difference. You have difference only during the day.
Merci, vous êtes très clair. Merci.
Buon pomeriggio, grazie per la presentazione. Ho sentito che ha parlato dell'antibody drug conjugated therapy, ma a che punto siamo con la sperimentazione? Ci sono già dei farmaci disponibili e sono già somministrati anche ai pazienti, quindi?
So these antibody drug conjugates are, let's say, their development is very fast. The drug is available for breast cancer patients. Well, one drug is available for breast cancer patients. Well, in fact, two, but one new drug and one old drug. And for lung, not at the moment, but it should come quite quickly. These are not perfect drugs, let's be clear. As I said, you feel like chemo, and they have also additional toxicity, in particular lung toxicity, that appears after 4 months of treatment, and we don't understand exactly what is the cause of the toxicity. It can be a real issue for the patients that are already some lesions in the lung. They might have severe toxicity. I mean, it's just to say that they are not perfect, they have advantages, but there are also cons. I'm pretty sure that in 3 years, we will have some of these drugs available to prescribe. I don't know if there is in Italy an expanded access program. No. Like in France, no. Clinical trials, but no expanded access program, no early access to the drug yet.
E saranno i primi ad arrivare saranno per i GFR o ci saranno anche per altre mutazioni?
So there are 2 categories of antibody drug conjugates. You have those dedicated to tumor addiction. So there are drugs dedicated to EGFR mutations, to MET amplifications, and there are drugs that are agnostic, broad, where we know that all the tumors will express the target, like TROP2, it's a target that you will hear in a few years probably. And for these drugs, you can give them whatever the molecular profile. So we will have ADCs for specific population, and let's say ADCs like chemo for everybody.
Ok, grazie.
Buonasera. Allora, qualora ci fosse una remissione totale della malattia, dato che la ricerca sta andando avanti, è possibile ridurre il farmaco oppure negli anni pian piano eliminarlo, qualora ci fossero sempre queste TAC negative con la remissione totale per tanto tempo?
Donc la question c'est réponse complète. So it's a very difficult one. Reduce the drug, I'm not sure. I think that either you take it, either you don't. But in between, the risk is to induce resistance. So probably either you take, either you don't. There is no rule. There are positions, let's say. My position is always to keep the drug because in some other diseases, we have seen that in general, when you stop the drug, at one point, the disease will come back. What I like to say to my patient is, it's not because you don't see anything on the CT scan that you don't see anything with a microscope. Meaning that when, you know, the CT scan, the limit for detection is 2 millimeter. 2 millimeter, well, it's 3 millimeter. 3 millimeters, it's 6 million cells. So in fact, the CT is quite precise, but still it's a tool that is really probably suboptimal. How we can move forward and try to get new tool? Well, there, liquid biopsy could be interesting. Me, today I keep the drug. I prefer to keep the drug. Let's say I said, if the safety is okay, I prefer to keep the safe side and keep the drug. But this can be discussed. Maybe in the future, with a blood test, you will be able to say, well, it's very safe to stop. The disease will probably relapse, but given the level of blood, probably in 2 to 3 years, and you will be off treatment during this time. And maybe it's good for even for the disease to be off treatment, because it could reduce some resistance. Just to say that today, it's something you discuss with the patient. It's a risk you take, but I mean, on both sides. If really, and I have some patients that ask me to stop, I follow them very closely, at least at the beginning. I see them each 3 months. I don't say, well, okay, see you in 6 months. You see, I prefer to watch if there is no early relapse. This is for targeted therapy. For immunotherapy, it's a bit different.
Grazie.
Se non ci sono altre domande, congederei il professor Bess, che per me è veramente uno degli esempi, non dei pochi, però uno degli esempi di come un grande ricercatore, lui è responsabile della ricerca clinica al Gustave Roussy, possa essere anche una bellissima persona. E lo saluterei e do la parola a Stefania, che non vedo, eccola, e così andiamo avanti con il pomeriggio. Grazie.
La persona che vi presento adesso la conosco da tanti anni, è una persona che stimo molto, ha lavorato 25 anni nel mondo farmaceutico e 5 anni fa si è ritirata perché aveva ricevuto una diagnosi di tumore del polmone ALK positivo e dal 2018 è fondatrice e presidente di un'organizzazione che si occupa proprio di persone che vivono con un tumore del polmone ALK positivo. È un'organizzazione che fa tantissime attività. Lei, oltre ad essere una paziente, è una patient advocate veramente molto molto appassionata di quello che fa ed è considerata veramente una voce autorevole nel suo paese. Quindi è veramente con immenso piacere che vi presento Debra Montag. So, Debra?
Thank you very much indeed.
Yeah, the floor is yours. Thank you.
Thank you. Hello, everyone, and apologies for not being able to be there in person. I very much regret that. Thank you very much indeed for asking me to speak today. And I'm going to take you through some of the advocacy work that we have done at ALK Positive UK. But first of all, I thought it would be useful to introduce you to myself and my journey with ALK positive lung cancer. I was initially diagnosed in October 2016, and I was prescribed crizotinib in the November. By January, I had developed a DVT, and I spent the next 2 years injecting daily until I was put on an oral therapy, which I still take today. In March, of 17, I then developed fluid in my lungs, which needed draining, and I had a chest drain for 6 months. It once fell out on the kitchen floor one evening, but it was surgically replaced very soon afterwards. In August of 2017, it was obvious crizotinib was no longer working, and so I was switched to alectinib. In March of 18, I developed a very rare side effect or complication of alectinib, where I developed a perforated bowel, and I spent 6 days in hospital without food, waiting for it to heal. And anyone that knows me knows I like my food. And so 6 days not eating was purgatory for me. In March of 19, I had radiotherapy to 2 spots that came up in my lungs. And I've recently had more progression in July of this year. We are currently watching and waiting. I have more scans in December when we will make a decision as to if I move on to lorlatinib. But so far in my journey, I've had 8 months on crizotinib, and I'm currently 54 months in on alectinib. So that's my journey so far. Now, when I was first diagnosed, I joined the US group of ALK Positive, which was a fantastic resource and support to myself. But over time, became aware that it had some limitations. And so I felt it was time that we had a charity in the UK. And some of the reasons that I felt it was necessary was that access to drugs and treatments in the UK can differ quite differently to the US. And so when patients were posing questions from the UK, what next? Some of the responses we were getting from US colleagues weren't applicable for us. And that could lead to a level of frustration in some of the UK ALK patients. Our reimbursement process is very different. And we have a separate regulatory authority that controls which medicines are available to be prescribed and reimbursed. Having worked in the pharmaceutical industry prior to my diagnosis, I actually knew that in order to get funding from pharmaceutical companies, it would be far easier if we were a registered charity. It enabled them to engage with us much easier. And also we wanted to build our own brand to be recognised by healthcare professionals in the UK. We felt again that if there was a UK organisation, that we would be listened to more strongly by UK oncologists. And so we set the charity up. First of all, one of our key aims, and it still is today, is support for ALK positive members. We have a closed Facebook group with which is only applicable for patients and their family members to join. And this gives people a fantastic opportunity to share experiences and give and receive mutual support. When I was first diagnosed, I met a fantastic lady by the name of Carolyn, and she got me through my first 6 months of diagnosis. And I just felt that everybody needed a Carolyn. And so I feel that this Facebook group gives everybody an access to a Carolyn of their own. People make friends. The majority of members actually call this their second family. And so it's a very friendly and open group where we spend a lot of time supporting one another. It's a very happy group. We celebrate each other's birthdays and any other life events. Some people have become grandparents for the first time. Some have got married. We also celebrate all cancerversaries. So it's a very positive forum. There's not a lot of doom and gloom in it. We also have held pre-COVID a number of patient forums where we've invited an ALK expert to come and speak to us. And so we held 2 of these each year. So we'd held 4 before the pandemic hit, where various oncologists would come and speak to us, and patients we would get together for the day. And again, people could meet and put a face to the name of people that they'd been talking to on the forum. Once the pandemic hit, we started with some Zoom activities just to keep, because people started to feel very, very lonely. So we have a Zoom coffee morning. We have a Zoom get together one evening a month where we meet at the Alki Arms, because that we have pubs in the UK. And so we wanted to replicate that sort of experience. So people bring along their own alcohol and bar snacks. And we just have a chat about anything and everything. And we set up our own exercise group as well on Zoom. So we started doing a lot more by Zoom since the introduction of the pandemic, and all those things have continued. We also felt very strongly that we needed to empower patients. And so we have a website we keep up to date with a wealth of information on treatments that are available and research that's being carried out. The empowerment also came through patient forums, that they could hear other people's stories and also meet the experts, because across the UK, some patients are being treated at cancer centres of excellence, whereas others are being treated in much smaller general hospitals where their oncologist isn't even a lung expert. And so we felt that we either had 2 ways of advocating. We either advocated directly to oncologists, or we could empower our patients and our members so that they could go out and be their own advocates. And so that's what we've been doing with a great deal of success. And then from an advocate point of view, we've been building up partnerships over the last 3 years, because it was said at the very beginning in the video that together will be easier. And I very much believe that it's much easier to do things together than on your own. We've built up a lot of alliances. We've attended several conferences and spoken at them. And I spend a lot of time networking to get the word out about ALK-positive lung cancer. And we've also carried out some very interesting members surveys, which has given us access to a lot of real-world data. And that has been invaluable to share with oncologists and also pharmaceutical companies, where we've been able to show the discrepancy across the UK of level of treatment. An example of this around MRI scans, which I'll come on to some work that we've done with that in a minute. So this is picture of one of our patient forums, and as you can see, it was very well attended. And to continue that on next year, we're planning the first patient conference in the UK, where we're hoping that 100 people will be able to attend. We're looking at the moment it being in face-to-face, but we may have to look at adding in the facility for virtual attendance as well. In terms of the empowering patients, as a consequence of some of our surveys that we've done, we were able to put together a good practice guide on what was best practice for patients in terms of frequency of scans, frequency of MRI brain scans, management of blood clots, things like that. And because it was evidence-based through the experience of the patients from centres of excellence, we've been able to get this booklet endorsed by 3 key ALK experts across the UK, and you'll be able to see on the visual there. I can't see what they've written, but basically they're endorsing this, and the lead ALK expert in the UK has also put his name to this. So that's given our members a great deal of empowerment to take this document to their oncologists, again, to be able to have a better conversation and advocate for themselves what best care and best treatment looks like. We've also been involved in the approval of 3 treatments by the regulatory body in the UK called NICE. And this was just an email that we received back following one of our submissions, where what we were hoping to do was to bring a great deal of insight into what it's like living with ALK, and so the need for new treatments. And I think we're going to take it as from the feedback that we achieved that, certainly on that occasion, which is great to know, because the more people that fully understand the implications of living with ALK, then when new drugs are identified, it will be easier to get those approved. So this is one of the pieces of work I alluded to earlier when I talked about we'd done some work with brain mets. And so what we did was we surveyed our members, and we found that only half of them were having a brain scan on diagnosis. And yet, despite the data that up to 70% of our patients develop brain mets, and actually only 42%, 42% don't receive regular scans either to watch for the development of brain mets. So we've put together some abstracts, and we've attended conferences with this data. Because it's real world data, people have sat up and listened. And this is one of those posters that we presented at the World Conference on Lung Cancer. We've also presented similar work at a British oncology conference last year. And as a result of that, one of the pharmaceutical companies has picked up this work and is now working with us to look at how we can improve the management of brain metastases before and after they develop in patients in the UK. So I'm hoping that we'll have further news on this area in the future. But this all came about through the piece of work that we'd done, the real world data. So, and that was testament to all our members taking part in the survey. So it meant that the data that we had was very strong and stood up to scrutiny. I do believe it's easier to do it together. And so we are a member of many different organizations and are aligned with many. So I've spent the last 3 years building links with, as you can see, all these various organizations and bodies. And many of them have led to opportunities to share information and raise awareness of exactly what ALK-positive lung cancer is and what the needs of our membership are. And so I would say any opportunity to network is a great opportunity and invariably leads us somewhere that enables us to advocate further. Our membership is important to us, and so we are constantly trying to find new members. And by, again, demonstrating our value as an organisation, it gives oncologists confidence in referring their ALK patients to us. And so in the beginning, when we started off with 54 members, and we're now up to nearly 450. So, but we have a way to go. We believe that there must be over 2,000 ALK patients in the UK. So we've still got a way to go. And this is what it looks like on a map as to where our members are. So you can see we've got good coverage across the UK, but we've got a way to go. So what next in terms of advocacy for us? So we certainly don't think our work is done. We certainly want to increase our advocacy so that we can find more patients. So we need to continue to engage with healthcare professionals, show them the value of support groups such as ours. And we have data on that. And again, we have shared that with some. We will continue to highlight that. Patients have fed back just how valuable support groups are, and being able to learn from each other and become stronger advocates themselves. And as a result, some have been able to get their stories in local newspapers, which is great, again, for raising awareness and destigmatizing lung cancer, because that's the only true way we're going to get acceptance and further research is by destigmatizing this awful disease. We want to continue developing guidelines for our members as well. One of the new areas that we've also identified a need is where CT scans are done, or how and what area of the bodies they cover. Some patients are receiving thoracic scans only, whereas others are getting their pelvic area scanned. And so we want to get some consistency, because we believe that the greater consistency we can get for all patients across the UK, that will improve overall survival. So just leaves me to say thank you very much for inviting me today. I can't stress enough how strongly I believe advocacy is important. There's nothing like hearing it from the horse's mouth, so they say, and clinicians are interested, payers are interested, they don't understand, and the real world can look quite different to that on paper. And so we've got a lot of work to continue. But as the video says, together we'll make it easier for ourselves. So thank you very much indeed.
Debra, ti vorrei ringraziare da parte mia e da parte di tutte le persone presenti, perché la tua presentazione veramente dimostra una volta in più come anche il mondo dell'associazionismo stia evolvendo insieme a tutto ciò che la ricerca clinica ci sta consegnando in termini di risultato, quindi non più solo associazioni che fanno supporto e informazione, ma che si fanno proprio portavoce di quelle che sono le istanze dei pazienti, i bisogni, e che quindi si siedono ai tavoli anche più tecnici, ai tavoli importanti dove si prendono le decisioni. E prima di lasciare spazio a qualche domanda dal pubblico, ti volevo chiedere una cosa. Abbiamo detto appunto più volte che together will be easier. Ho visto che in pochi anni la vostra associazione è passata da 55 a 420 membri. Questo è veramente un risultato molto importante e molto incoraggiante anche per noi che siamo qui oggi. Qual è il segreto? Cioè, su cosa avete puntato? Quali sono state le attività che hanno in qualche modo fatto sì che anche le persone magari più restie si siano avvicinate all'associazione, si siano fatte coinvolgere da tutto quello che un'associazione può rappresentare e può dare? C'è la traduzione.
Ha sentito? Noi abbiamo tradotto.
Sì.
We have translated, but can you hear us?
Oh, hello. Yes.
Yeah.
Hello, nice to meet you. So I repeat again the questions because
The question is for you.
Yes. The question is, we have seen that you have increased so much your number of members over the last 3 years. So we want to know what is the reason why you achieved this result, what a sort of miracle for them. So what can we do? How can you explain this successful result?
Okay, so what we did was when we set up the group initially in the UK, we invited everybody that was living in the UK that was a member of the US group to join the UK group as well. And then we developed some leaflets, some simple leaflets as to what the group was about. And we gave them to those members who took them into the hospitals, and they gave them to their nurses and their oncologists and encouraged them to give them to any other ALK patients that they had. I also presented at a number of hospitals. So those patients would also say that the chair of the support group would be very happy to come and talk to you about the work of the support group and what it does and what it doesn't do. And so I ended up presenting a number of times to different nurse groups. So just to reassure them that we weren't doing anything or suggesting anything that wasn't evidence-based. Medics have a natural skepticism with online support groups, and I think it's a healthy skepticism to have. But we needed to reassure that we weren't allowing any discussions around off-license use of medicines or anything that wasn't evidence-based. And when we were able to reassure them, we made our website open. So again, all healthcare professionals could see our website as to what we were putting. We've gained their trust that way. And so more of them have been, as new patients have been identified, they've started to recommend them. We've also attended some conferences where we've had opportunity to talk to healthcare professionals and again hand out our leaflets, and that's gained traction. And patients have found us directly. People have Googled when they've been diagnosed and found our website, and we have a direct link to with an email to myself where I welcome all new members. And so it's been a multi-pronged attack.
No? Se c'è qualcuno dal pubblico che ha piacere di fare qualche domanda.
Posso star seduta, immagino, in questa circostanza, no? Ah, ok. Innanzitutto ringrazio perché è stato un intervento veramente molto interessante. Una paziente che è riuscita, a intraprendere un percorso di questo genere, aiutare anche gli altri, sicuramente ad esempio. Visto che abbiamo capito l'importanza dell'advocacy, che è fondamentale per avere un accesso, anche più rapido alle cure e per migliorare le nostre condizioni di vita, ci può dare, quali sono gli ingredienti fondamentali per poter essere efficaci in questo ambito, per poter essere incisivi? Come avete fatto voi a portare avanti delle istanze che siano state poi riconosciute a livello nazionale?
I'm really sorry, I couldn't hear the translation clearly. Could you summarize that question for me, please?
Dove lo ripeto?
Qui a Roma, prego.
Devo dirlo? Quali sono gli ingredienti per...
Aspetta,
okay.
No, perché non mi sente. Non sente.
Hello?
Hello, can you hear me?
Yes, I can.
Okay,
Unfortunately,
okay,
I couldn't hear your translation very well.
That's right.
Could
because we are using 2 microphones. I'm sorry.
Right. It's okay. Could you just summarize what the lady asked?
Yeah. Actually, you represent a great example for us because you are the example of a patient who managed and was successful in creating and founding an association and so on and so forth. So what are the main ingredients of this success? How can we, so because you had a way to be successful at a national level. What can we do? What are the ways to get to that point?
Okay, I think you have to have a passion to want to make people understand and be aware, and you need a dogged determination to keep going. And networking is incredibly important. So joining other organizations that have similar objectives, so other lung cancer organizations, maybe other organizations for rare cancers of any type. I think you will learn. I learned so much from other organizations in the early days. I think talking to healthcare professionals, and if I spoke to one, I would then always ask, who else do you think I should talk to? And I was then cheeky enough to say, could you make the introduction for me? So one led to another and then led on to another. Leaving no stone unturned as well. I just think to have a plan and to be clear on what your plan is, be clear on what you want to achieve and what you don't. It's as important to be able to communicate what you're not about as what you are about. And to keep going, to reassess every 6 months, and to look what you have achieved, to celebrate those achievements, and to make sure people know about the achievements. We use social media, which helps, and we tag organizations with lung cancer oncologists and lung cancer nurses so they can see the work that we're doing. And it's just a case of raising noise. But the right noise, making sure what you say is very clear, your messages are very clear, they're not outside the realms of what clinicians are talking about, and be clear that we have a lot of value, especially as a group of us. We can share our experiences. You know, we looked at the side effect profile of all our medicines, compared them, and it was real world data. And again, pharmaceutical companies have been very interested in that because trial data can look very different to real world data. And so there's pharmaceutical companies are always looking to engage with patients in a safe, compliant way. And by being an organization and advocating strongly for patients, then it gives them an opportunity to engage with us in a safe environment.
So, Deborah, I really thank you for your valuable suggestion, and I really hope to see you soon somewhere. So, now, adesso do la parola al dottor Galetta, and Deborah, see you next time. Thank you very much.
Thank you very much indeed.
Aspetta che deve...
E quello che sta avvenendo oggi è una cosa straordinaria, fantastica, e che 10 anni fa non avremmo mai pensato che potesse accadere. I pazienti non operati, ma i pazienti con un tumore polmonare che si trovano assieme ai loro medici e assieme ai loro caregiver a condividere un momento di incontro in maniera serena, potendo porre delle domande, è una cosa fantastica. È una cosa molto bella ed è un'emozione reciproca. Non è un'emozione solo per i pazienti, è un'emozione anche per noi medici. Io credo che, lo diceva prima il professor Bess, i pazienti in questo momento sono di aiuto ai medici, voi siete molto di aiuto a noi, perché dove c'è un farmaco e non è possibile poterlo ottenere in tempi brevi, è possibile che siano i pazienti a essere forti da poter ridurre il tempo di accesso al farmaco, ai farmaci, perché non c'è un tumore del polmone, ci sono tanti tumori del polmone, ci sono tanti farmaci e c'è tanta ricerca. Molto spesso alcuni pazienti sono più informati dei medici sui trattamenti disponibili e questa non è una cosa negativa. Non esiste più la bilancia del medico e del paziente. Esiste un momento di stare assieme sullo stesso posto sapendo che il tempo dell'informazione è un tempo importante, il tempo della conoscenza è un tempo importante, ma questo rende noi tutti partecipi di un percorso comune. Quindi questo incontro è un incontro bellissimo solo per il fatto che è una cosa unica nel suo genere, ma è una cosa che avrà sicuramente, grazie ai progressi della scienza e grazie al paziente che diventa sempre più curioso, non dottor Google, ma curioso scientificamente attraverso i dati della letteratura, i tanti studi che sono in corso. Capite bene quanto è importante anche il radon e scoprire magari che nelle nostre case c'è una causa, lo abbiamo tenuto per tanto tempo e non lo sappiamo. Ciò detto, a me tocca presentare, non posso dire una paziente, dico un'amica, una suggeritrice. E tra l'altro io che sono tifoso dell'Inter, quindi tifoso di una squadra che è nero-azzurra, noi non amiamo la vita senza colori, amiamo la vita con i colori, ha un colore, ci ha fatto molto affezionare al colore azzurro ed è a Roberta Costa, che nasce in Sardegna e in questo momento fa le sue vacanze a Bari, che io lascio la parola. Voi avrete trovato nelle vostre cartelline questo piccolo volumetto che è l'azzurro di cui Roberta Costa adesso vi parlerà per un attimo. E grazie ancora a tutti voi.
Questo è il Be MUT-ual. Vi tremano le gambe? Beh, a me 3 anni fa tremavano moltissimo. Oggi, più di 3 anni fa. Va bene, sono qui soltanto per spiegarvi che cos'è questo omaggio, però lo devo anche motivare un po' di più. Quindi ho preparato una prefazione alla prefazione. Innanzitutto voglio dire che per caso sono di nuovo qua, perché essendo questo un congresso divulgativo, l'anno prossimo il parterre sarà di altri pazienti, per cui veramente con gratitudine ringrazio la professoressa Novello e WALCE per avermi nuovamente invitato. E forse è stata anche questa, diciamo, l'idea che poi ho voluto portarvi un regalo. Va bene, adesso ve lo spiego. Quando stamattina pensavo questo, quando si sono conosciuti momenti come questi, come quelli che io ho conosciuto nella mia vita, capisci per sempre che ogni istante di felicità della vita, nella vita, è un regalo. mai come ora ho desiderato di vivere intensamente il mio presente e sono consapevole e cosciente che tutto possa veramente finire dall'oggi al domani. È già successo. Però so anche che mai nella vita niente è definitivamente disperato. Ho fatto mia una frase raccolta in uno dei miei quadernetti dove io trascrivo le frasi dei libri, e infatti non mi ricordo il libro da cui l'ho presa, però diceva così: rendi sempre i regali che hai ricevuto, ma non necessariamente a chi te li ha donati. A ottobre del 2018 fui invitata dal dottor Galetta alla presentazione di un cortometraggio dal titolo Apolide, che poi fu presentato proprio al primo congresso del Be MUT-ual Days a novembre del 2019 qui a Roma. Ero nel periodo più buio, vivevo un momento proprio in apnea, che è una cosa che forse qualcuno di voi sa cosa significa, vivere senza fiato. Quando ti dicono che hai un tumore al polmone, cominci a pensare che forse il respiro si sta bloccando. Ed ero sgomenta, ero terrorizzata, proprio da questa diagnosi molto recente. L'unica consapevolezza che ho avuto da primo momento era quella di sapere che ero nelle mani della persona giusta e non capivo altro, non volevo sentire altro. Non riuscivo a parlare al mio medico nel timore di sembrare una paziente un po' stupida, soprattutto non all'altezza del suo medico e neanche del suo tumore. Una volta il dottor Galetta, in uno dei nostri incontri, mi disse: ma tu sei brava a scrivere, e allora scrivi ogni giorno una frase che possa servire a te, però anche a me. E io così ho ripreso a scrivere, però non a trascrivere, a scrivere. E quindi ad annotare i miei pensieri, e alla fine la scrittura è diventata la mia terapia, perché io scrivevo quello che sentivo, senza necessariamente dirlo a voce alta, senza necessariamente dirlo ai miei vicini, agli amici, per cui era una forma, l'ho chiamata la mia terapia integrata, perché quando scrivi visualizzi e cominci a stare meglio. Va bene. Nel presentare Apolide, il dottor Galetta disse che le storie belle meritano di essere raccontate. La storia bellissima di Apolide mi aprì il cuore e mi riaprì il pensiero e si riaprì anche il mio respiro. Volevo essere anche io una storia bella da raccontare. Apolide era una storia venuta dal mare e restituita al mare. Molti di noi sono apolidi, alla ricerca di una terra ferma, ma chi viene dal mare conosce il moto ondoso e sa. Azzurro per sempre questo quadernetto, è il formato di un quaderno, proprio perché io da sempre raccolgo in quadernetti di questo genere i miei pensieri, le frasi, le canzoni, tutto quello che è. Ho deciso di scriverne uno in cui ho provato a esprimere a parole una emozione, comunque un pensiero colorato. Il mio omaggio molto personale a Be MUT-ual Days nella sua terza edizione in presenza, perché il primo congresso nel novembre del 2019 mi ha regalato la consapevolezza di un cambiamento di status nella mia persona. Da persona normale sono diventata una paziente, un cambiamento inevitabile come il respiro. Senza respiro non puoi vivere, e vivere con il cancro al polmone toglie il fiato e toglie il respiro. Però questo quaderno ha i colori del mare Adriatico, è infinito, umorale, burrascoso, irascibile, però è carico di energia, diventa anche quieto, trasportatore delle mie contraddizioni, delle contraddizioni dell'umanità intera. L'Adriatico è un mare fra due sponde ed è bello guardare l'orizzonte e sapere che oltre quella sponda ce n'è un'altra. C'è un probabile approdo. Mi chiamo Roberta, sono nata in Sardegna e trapiantata da bambina, radicata in Puglia. Sono nata nell'azzurro mare di agosto e il mare e i colori sono la mia chiave di lettura della vita. Ho 66 anni, diagnosi gennaio 2018, adenocarcinoma polmonare in 4º stadio, non fumatrice. Fino ad oggi e per sempre in cura presso l'IRCS di Bari, in terapia a bersaglio molecolare guidata dal mio unico dottore Galetta. Dal giorno della diagnosi ho vissuto in apnea, scrutando il mondo dalle costole della cassa toracica e trascrivendo emozioni. Al primo congresso nazionale dei Be MUT-ual ho capito tanto. Forse troppo poco, o forse molto, non lo so. Non vi racconterò niente della mia vita di prima, neanche della rabbia, della paura, dell'incredulità che mi hanno assalito, né di cosa un tumore toglie o dà, perché dà tantissimo, perché non vi direi niente che non sia già stato detto, pensato, scritto, provato da voi. Partirò dal giorno in cui ho avuto la percezione che il mio orizzonte si fosse capovolto, dalla paura di non rivedere più il mare. Sono sola con me stessa, spesso, sempre. Da quel giorno ho ripensato a tutto e non ho provato rimpianto perché non avevo rimpianti. Era la mia vita bella. Ho provato solo paura di non avere più il tempo. La lettura, l'ascolto delle canzoni, la scrittura sono stati il mio itinerario e inventario sentimentale e mi hanno aiutato a non allontanarmi mai dal dare attenzione al genere umano e cercare occasioni di colloquio e di confronto. L'amo a cui abboccare per convincermi che devo affrontare la malattia come normalità, occasione che la terapia mi concede. La difficoltà è contenere le emozioni, venire a patto con l'invisibile, è l'ostacolo che divide la mia vita e la visione della vita tra il prima e il dopo, il durante e il momento. Ho scritto, ho stampato il mio quadernetto, questo è il regalo per il nostro Be MUT-ual Days, abbiatene cura. Grazie.
Grazie a Roberta per questa testimonianza che si racchiude in queste poche e dense parole. Adesso c'è un momento di pausa, ma noi ci dobbiamo rivedere qua per forza, obbligatoriamente, alle 18:30, non un minuto di più, perché dobbiamo assistere a un bellissimo spettacolo teatrale di un'oretta e poi dobbiamo fare la nostra foto di gruppo. Per cui adesso in vacanza tutti, ma solo fino alle 18:30, poi ci rivediamo qua. A nome della professoressa Novello, 2 ore di vacanza romana.